I'm so honored to be doing a talk for Sosh Fair. As mentioned, my name is Leila Guller. I'm a clinical psychologist at McLean Hospital, where I work on a residential unit with teens and young adults who are struggling with a host of issues related to emotion dysregulation, including borderline personality disorder and substance abuse. I also have a small private practice on the side. And again, I'm just very grateful to be here and I'm excited to give this talk. So let's jump right in. What are we going to be talking about today? I'm going to spend a little bit of time talking about the data, the overlap between BPD and substance use, but primarily what I'm going to be talking about today is what are some challenges that are unique to family members that are dealing with loved ones that are struggling with these comorbid diagnoses, and what can you do about it? What are your resources? What can you do to support yourself and the person in your family? As I work with teens and young adults, a lot of examples I will use today will have to do with parenting people struggling with BPD and substance abuse. However, these examples can really go across the spectrum. So if you have a parent that's struggling with this, a sibling, a friend, right? I think many of these skills will apply across the spectrum of whomever you love, whether it's a child, a parent, etc. So let's dive right in. I'm assuming if you're here, you have some familiarity with what borderline personality disorder is, or BPD. So I won't go into a ton of detail about every single one of these criteria, but in general, what I would like to draw attention to is that BPD is a disorder that's characterized by emotion dysregulation, right? That can come out in interpersonal sensitivity, that can come out in emotions that can be really intense and all over the place, and that can come out in what we're most familiar with BPD is suicidality and self-harming behaviors. What we also see in BPD, and I'd like to draw your attention to, is criterion 4 here, which is impulsivity in at least 2 areas, not including self-harm and suicidal behavior. And one of these areas that we really commonly see is substance use, right? Which is a nice lead into my next slide. So what is substance use disorder? I'm going to spend a little more time here because I see so much misconception about what makes up a substance use disorder. Specifically, what I most commonly see from both families and clients alike is that people think in order to be diagnosed with a substance use disorder, you need to be physically dependent on the substance, so a physiological addiction, and that is not true. So that's why I want to go through these a little more. There's 4 general categories that can constitute a substance use disorder, and I'll color code it. The first general category is you have impaired control when you are around that substance, right? That can look like you use more than intended. You say, I'm only going to have a drink or 2 tonight, and you wind up having 6, right? It could be you keep saying, oh, I got to stop using the substance, and you keep coming back to it, right? I really like what they say in Alcoholics Anonymous. They use the term an allergy to alcohol. And I hear people say, that doesn't make any sense. Like, if you're an alcoholic, you're drinking all the time, can you be allergic? And what it actually means is that whenever you get around it, you have a bad reaction, right? So you might use more than intended, you might have negative consequences. I really like that term. The next category is like what most people think is the requirement, the physiological dependence. And this can play out as cravings and urges. You're sort of feeling it in your body that you really want it. You might build tolerance, so you need more of it to get the same effect, or you might have withdrawal. You have unpleasant physical responses when you cut down on use of the substance, right? So physical dependency is one of 4 general categories you can have. It's not the only requirement. You don't even need these symptoms to meet criteria for substance use disorder. The third category, and this is actually the biggest chunk, is social problems, right? You might be spending a lot of time on it. You might not be doing the things that you need to do, right? You're missing work. You're not, getting to school on time, neglecting your responsibilities. You might be doing it even though it's causing problems in your relationship, right? It could be as a direct result of the substance. You're getting into an argument with your spouse every single time you drink. Or it could be that everyone's really worried about you and they're saying, I can't watch you do this. This is awful, right? Social problems, and you're still doing it. Or you start giving up the things you care about. Lots of people that struggle with substance use disorder will stop doing their hobbies. They'll stop seeing people that they care about, right? Their whole life kind of becomes about the substance. The last category here in green is risky use. So this can be using in risky situations. That could be drinking and driving. That could be going to a drug dealer's house alone in an unknown location. Or it could be using despite health problems. So the classic example, of course, is people who have liver failure and they're still drinking. But what I see more commonly in teens and young adults is like a lot of lung issues from vaping, smoking a lot of marijuana, where people will like have these awful coughs and still do it. Okay, there's a range. So if you're meeting 2 to 3 of these symptoms, 2 to 3 of these criteria, you're going to be diagnosed with a mild substance use disorder. If you're meeting 4 or 5, that's moderate. And if you're meeting 6 or more of these symptoms, that's a severe substance use disorder. I will say in my residential setting, because we are not a substance use unit primarily, I most often with BPD will see the mild to moderate range in my setting specifically. However, I do often see the severe range as well. And that's typically with marijuana. I'll see, it's not uncommon to see daily marijuana users that are meeting 6 or even more of these criteria. Okay. So that is substance use disorder. Again, it is not just physical dependence. So how often do these overlap? Timothy Troll does awesome research on the overlap between BPD and substance use. And if you ever want to check out his research, and the overlap, the lifetime overlap, lifetime comorbidity between borderline personality disorder and substance use disorder ranges from 45 to 86%. It is high. That is not concurrent comorbidity, that is lifetime comorbidity. So these can occur at the same time or separately, but it's really, really high. And again, it makes sense that it's really, really high, right? So as I mentioned, one of the core features of BPD is this impulsivity and reckless behavior, right? Including substance use. We also know that you only need 2 or 3 of these symptoms to meet a substance use disorder. But really, I think that both disorders are really, really disorders related to emotion dysregulation, right? Most people that struggle with addiction are struggling because something internally needs to be addressed, right? They have trouble sitting with themselves. They have trouble tolerating their emotions. It's very similar to a lot of the symptoms we see with BPD. That is my experience. Okay, so we've got the data, high overlap. What is hard for family members? What I see generally family members struggle with are 2 spectrums of difficulties. The first you can see on this list is I really see family members struggle with a lot of non-acceptance and judgment when their kids, their family members have substance use issues. But even more commonly, number 2, especially for parents, what I see is this tendency to get really, really pulled in to over control and emotional reactivity. So I'm going to go through what both of those mean now. Again, the second one's the more common one I see for the parents at this talk. But let's start with the first one. This is not, I don't know if you guys can see it. I might need to move my picture. This is not a direct quote from anyone. It's sort of a summary just for the sake of privacy, but I've heard parents say things like, my kid's not an addict. She's just got BPD. She's just using drugs to regulate her emotions, right? To which I say, find me an addict who doesn't do that, right? Like I said in the last slide, substance use disorder is often a problem of emotion dysregulation, in my opinion. So this is something that parents struggle with a lot. I think they have all these preconceived notions. So they get into a lot of judgment of substance use disorder. So what does that mean? Lots of parents that I work with will think like, and not just parents, by the way, let me just say, society as a whole, I think, believes that substance use disorder and addiction is a problem of selfishness. It's a really unfortunate thing that I run across. I see a lot of families think that people that use substances are sort of just hedonistic and just want to get a fix and feel good. And therefore they have a lot of judgment about it, right? Like all you care about is feeling good. Related to that is just a fundamental misunderstanding of the function of substance use, right? So I'll give you an example. I worked with a family where the dad would say things to his kid in family therapy. Again, details are a little bit blurred, but would say things like, you're so selfish, like all you care about is getting high. You just go out with your friends. You don't care about your family. That's it. You just want to get high and have fun. And the kid looked at him and he was like, I don't really care about getting high and I don't even feel that good when I get high. I just feel so socially anxious, and I really like my friends and they all use substances, and I don't want to be the only one left out, and I feel like I'm crawling out of my skin when I'm around them, and it just feels awful, right? Like, and the dad looked at him like, oh, wow. And you could see like this moment of empathy building for the father, where suddenly he thought, oh, you're not just like this selfish kid that wants to get high all the time. You feel awful when you're out and you like your friends, right? A lot of families I see just don't get why the person is using substances in the first place, and that it's typically treating like a negative symptom like anxiety or panic or depression, right? People just skip straight to you're doing this to feel good and you don't care about anyone. And it's easy to do that. I understand. I do see some families very fearsome of the terms alcoholic and addict, with a lot of judgment towards those terms. And I think that goes back to how society as a whole kind of sees people that struggle with these things. What I will say is alcoholic and addict are very helpful terms that are frequently used in groups like AA and NA. I would not recommend you using the term towards your family member unless they're the first ones to use it. So like, for example, I had a kid that said to her dad that she was an addict, and the dad said to me separately, like, I really don't like that she's using that term. That's gonna, stigmatize her. I don't like it. And I said, that's what she's using in NA. Like, that helps her connect to other people and understand her behaviors. And he came to terms with it. But I wouldn't say anyone should use the term first, right? Only use it if your family members use it. In italics here, I have an issue that I see in judgment and non-acceptance that I think is very specific to family members with people with BPD that I sometimes see, where they'll actually minimize the substance use, because compared to things like self-harm and suicidal behavior, sometimes it doesn't seem that bad. I've had a parent say something like, I know my kid is smoking weed all day, every day, but she hasn't been to the hospital for self-harm in 6 months. I don't really care. And they don't really want to see the problems because it's better than the alternative. And, I think it's helpful to have a therapist on board that can assess, well, how is the weed impacting the kid, or whatever the substance is, right? So sometimes I see minimization. Now, like I said, judgment and non-acceptance, I see less commonly than our next issue, but judgment and non-acceptance can lead to a lot of anger, hopelessness, and fear, right? Like, if you think my kid is selfish, you're going to feel angry. If you think like my kid's destined to a life of being an addict, you'll feel hopeless, right? And fear. But like I said, the next spectrum of problems I see is much more common, and that is over control and emotional reactivity. And I'll hear parents say things like, can I just take everything away? Right? Can I just control everything and keep him from these people that he's using with, or whatever? Right. So what does emotional reactivity and over control look like? Like I just said, I see some family members, especially parents, but it can be other family members as well, really try to control their family members' access to people, places, and things. So like, I'm getting her laptop, I'm cutting off her phone, I'm not going to give her any money, I'm never going to give her the car, I'm going to follow her location everywhere she goes, right? It makes sense, right? When you're scared, we get really, really, really pulled into control. But what tends to happen is people just get better at hiding things when we over control, right? They just get a little sneakier. I see this one a lot. I'm usually on the other end of this, but family members, especially parents, because they have more control over their kids, will try to force their family members into treatment. What does that look like? So that can go hand in hand with the first one. Unless you go to treatment, I will never let you hang out with any of your friends ever again. I'm never going to give you money, right? So they sort of can coerce family members into getting treatment. And they might get there, right? I've worked with plenty of teenagers that show up at McLean and they're like, I'm literally only here because I was like in jail when I was at home, right? I was watched every second of the day. I didn't have my phone, et cetera, right? I will say that when people are coerced into treatment and they feel like they're really, really forced, it's harder for them to make effective use of treatment. Now, that's not to say you cannot set any contingencies, which we'll get into later, but when it's done in a reactive, forceful way, it doesn't really translate into behavior change. This is the one I see the most. I have fallen into this trap personally with family members that struggle with these issues. I see this all the time where people try to convince the other person that they have a problem. So I'll have parents sitting in family therapy say something like, I've had to pick you up at parties again. This is made up. Completely passed out 6 times in the last 6 months. Like, how do you not see that you have a problem? The kid's sitting there like, all my friends drank, right? It's not that, like, their parents just don't find out, but I'm not the only, right? The more you try to convince, the more the other person pushes back at you, especially if you're a parent. It just doesn't work. And it's really frustrating. I completely get it. Where sometimes you're sitting there and you're like, how are you not seeing what every other person around you is seeing? How are you missing this? Like, it is so clear that you have a problem, but the more you try to convince someone with words, the less likely they will be to admit it to you. And I'll say in a future slide, if you are a parent, you're probably the last person they'll admit it to. Again, italics means it's unique to BPD and substance use disorder overlap. I think it's so hard to avoid over control when you're scared. And when you have a family member who has made suicide attempts, who's self-harmed, that you're really, really afraid that their life is threatened, you're going to get pulled into over control, right? It's very different to have a kid that you're like, ooh, is he smoking too much weed or is he drinking too much? That doesn't have self-harm, right? To maybe step back for a little longer. It's much harder when you've had a kid, for example, who got drunk at a party and then got into a fight with her friends and then self-harmed and had to go to the hospital and get stitches, right? And then wound up inpatient, right? It's way harder to sit back and just watch, because for you, you're like, oh my gosh, when my kid abuses substances, they get to all of these life-threatening behaviors. You're scared, right? It's a unique challenge when you're a family member of someone that is struggling with both of these comorbidities, right? And I see it, and it's very, very, very hard. Like with non-judgment acceptance and non-judgment, you can experience a lot of anger and hopelessness and fear. Like, you're sitting across trying to convince someone, they're arguing with you, you're going to get mad. When you're afraid someone's going to have life-threatening behaviors, you will get afraid, you'll get hopeless, you'll get sad. Lots of feelings can come up, very similar on both ends of the spectrum. So that's painful, right? I'm describing a really painful process characterized by anger and fear and hopelessness and all sorts of things. So what can you do? I want to spend a little time talking about what you can do as family members for yourselves to take care of yourselves and your loved ones that are struggling. What I want to do is focus a little bit on skills that I teach people in my addictive behaviors group, because I think it's really helpful as family members to know the skills that your family member might be working on, but also implement them for yourself. I will only be going into detail about the stages of change and dialectical abstinence, which I'll get into in the next 2 slides. But very briefly, I want to walk through these 6 skills, just so you have a general idea of the types of things we work on in addictive behaviors groups. This would be 6 hours in group settings. I'm going to do it in 3 minutes, hopefully, but I want to go through it quickly. Stages of change, which we'll get to in the next slide, is the idea that a person's readiness to change dictates how successful they are to change. It's helpful for family members to know what these stages are. Dialectical abstinence is the idea that you are making a full commitment to stopping the addictive behavior with a plan in case there's relapse. Clear mind is the concept that you're able to celebrate your successes in sobriety while being very hyper-vigilant of the risks for relapse. Community reinforcement is the idea that you need to build your life in a positive way outside of your addictive behavior, in a way, hopefully, that's incompatible with the addictive behavior, right? In AA groups, they use the term dry drunk a lot, which means someone that's technically not drinking anymore, but still living like a drunk, meaning they're pretty miserable, right? They haven't built their life outside of the addiction. So community reinforcement is a way to not become a dry drunk and have a life, which makes the risk of relapse much lower. Burning bridges, building new ones, I'll just talk about burning bridges, is the idea of totally cutting off your access in any way possible to your addictive behavior. The concept of this group is that your addiction is like an elephant that's standing in your driveway. And if you leave your garage door open even this much, it can slip its trunk in and pull the garage door open and stampede into your house. right? So it's the idea of basically cutting off your access in any way possible, letting people know you've quit, throwing out paraphernalia, etc. And last but not least, alternate rebellion, kind of related to that, having some fun in your life thing. If addictive behavior serves as some sort of rebellion, you need to find a different way of scratching that itch of being a little bit rebellious in a way that's safe and won't ruin your life, right? I'm just giving an overview of those skills just briefly in case any of you have a family member that winds up in a DBT for addictive behaviors group, sometimes called DBTS, substance use groups. But I'm just going to focus on these first two. So stages of change. It's helpful for family members to know what stage of change their family member is in. And on this slide, I want to define what each stage is, and then talk a little bit about what you can do as a family member while they're in these stages from your point of view. So we're going to start in this corner right here, pre-contemplation. Pre-contemplation is when someone is typically still in the behavior and they're not considering change at all yet, right? There can be two reasons a person might be in pre-contemplation. One is they're actually completely unaware that they even have a problem, right? Like they don't even realize it. The other can be they're aware, but they're just totally unwilling to change it, right? So they're like, oh, I know. You'll hear that with smokers sometimes. They'll be like, I know this is bad for me. I don't care. That's pre-contemplation. As a family member, what I would recommend, this goes back to our slide on over control. You can't really effectively with words convince your family members to get out of pre-contemplation. Like if someone is in pre-contemplation and you try to say, don't you see this is a problem? It doesn't work that well, right? It just doesn't work that well. So I just want to harken back to that slide that sometimes if someone's in pre-contemplation, from you, it requires a lot of non-attachment. Take a deep breath, step back, self-validate. This is really hard. I'm not going to be able to convince them. I hope they can change, right? But you can't really like force someone into realizing they have a problem. Contemplation, right, is when a person starts thinking about changing, right? It might be, oh, yeah, maybe I don't do this the same way as my friends, or maybe I could be happier doing something else. Right? It's just you're thinking about change. You're not doing it yet. You're not really taking steps yet. You're just starting to think about it. What I'll say, if you're a family member who has someone in contemplation, is don't jump the gun, right? If someone says something like, you know, I think I'm smoking too much weed. It would be so easy if you're a concerned family member to be like, yes, let me help, right? And you just jump in. Sit back and sort of observe and say, oh, wow, what makes you think that? Be curious, right? What I want to say before I go to the next one, I tell parents, this is especially true for parents, you are often, not always, it depends, but often the last person to know if your child has shifted into contemplation. So I'll give you an example. I've worked with someone whose parent did the thing of like, don't you see this as a problem? I had to pick you up. And the kid's saying, my friends do that too. Their parents just don't know, blah, 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 right? That kid is fighting their parent tooth and nail in family therapy. And then there'll be an individual therapy with me alone, no parent present. And the kid will be like, oh, I know I have a problem. Right? So they actually are in contemplation, but the parent doesn't know it. Right? I see that all the time. And I think there's a couple of reasons this happens. I think one, kids have some fear of punishment if they do admit to their parents that they have a problem. But I also think a sweeter reason is that kids always want to maintain a little bit of innocence with their parents, which might be strange for this group to hear because you've probably been through the ringer with some of your kids. But I think even with that, they still want to maintain some image of like, I don't have problems, I'm still your kid, right? So parents are often the last to know. And I just wanted to say this here because in some ways, I think it can help you take a step back and say, you know what, like I'm really frustrated. It looks like she has no idea that she has a problem, but maybe she realizes more than I know. And I think the stance of not knowing with certainty what's in your family member's mind is a very helpful thing to maintain. So I just share that example to say oftentimes parents don't realize when someone's in contemplation. Next step. Preparation or determination, this is when you are ready to change. You're like, I'm making a change, and you're considering how to do it. You might be reading books, you might be looking up meeting times, you might be telling people that you're getting ready to quit, right? This is when you're towing the line of taking action, right? Once again, so if you see your kid or your parent or your aunt or your uncle or your friend say something like, thinking about checking out an AA group, play it cool, right? Don't jump straight to like, oh my God, okay, I'll help research it. Let me go ahead, and you go straight to your laptop and you print out a list of meeting times, right? There is nothing that will make a kid back off quicker than if you do that, right? Imagine you said to your spouse, I'm thinking about going to the gym, and he or she comes home with a bag full of spandex and sneakers and says, here you go to the gym. You'd be like, ew, I don't want to do that, right? So same thing for your family member. If they start taking those steps, I don't encourage you to say nothing, but be encouraging, all of that. Be like, that is so awesome that you're looking at those meetings. Like, you can ask questions, say, what made you decide to do that? You can tell them you're proud of them, all of that. It's not like don't have any response, but please do not swoop in and do the preparation for them. Don't be overly eager, because it usually makes people back off. All right, next step is action. That's when you're doing it. You are in action, you're changing the behavior, it could be going to a treatment program, it could be going to groups, it could be getting a therapist and seeing the therapist, it could be stopping the behavior, right? That's action. You have made the change and you're doing it. Once again, you can praise, you can reinforce, you can tell the person they're doing a great job, you can be curious, but don't swoop in and try to keep the action going, right? Same thing as step 3. Last but not least, we have maintenance. Maintenance is when you have made the change and you're keeping it up. You've built your life in a way that sustains the behavior change. This is the stage that both patients, clients, and parents and family members alike tend to have the most trepidation about that I work with. So for example, most of the clients I work with will say something like, maintenance is forever. Forever is scary. I don't want to do this. How can I possibly never, ever drink again or use drugs again or self-harm again, right? I hear people feel a lot of anxiety about this, and parents and family members say, how is this going to work when she gets home? Or how is this going to work when she goes to college? Like, how is she going to keep this up? And what I say to patients, and I think it's helpful for parents and family members to hear as well, is it really feels less and less like forever the further out you get. So let's say you're discharging from a residential program. It does feel a bit like a fight early on. It feels like you're resisting a lot of urges. You have to say no, you have to hold back. But the more you refrain from the behavior and the more you build your life outside of that behavior in an effective way, the less it feels like that active fight and the more it becomes an afterthought. So it really doesn't feel like this forever, I can't. People get hit with urges at random times over the course of their life, but it gets easier. And I say this because I think there's an overlap with parents as well. I think it gets a lot easier for parents as time goes on as well. So breathe, sit back, realize that it's going to get easier for a kid, and hopefully it'll get easier for you as well. And last but not least, this is very important to mention, relapse can be a part of the addiction cycle, right? So you can have maintenance, people can have time where they're clean and sober and away from the behavior, and then they can relapse. Not always. I have plenty of people I've had some follow-up with over the years that have left our residential treatment that have not relapsed once. I work with people that have lots of relapses and then finally make a sustained change, right? Relapse can be part of it. It's really important to mention, because if you don't even have the option in your mind that relapse can happen, you're not going to know how to deal with it, which is a very nice segue to my next slide on something we call dialectical abstinence. So dialectical abstinence is this concept of how do you approach recovery, right? And it takes from two models that are seemingly on polar opposite ends of the spectrum, and it synthesizes the two of them. So let's introduce you to those. On one end of the spectrum, is this idea of abstinence, right? An abstinence approach to recovery or behavior in general is never do it. You just cannot do it. It's not an option. Don't do it. Never again, right? There's some pros of that. There are some benefits. If you have that approach to your recovery, you don't have as much room in your mind to slip, right? It's more final, it's more all or none. Abstinence can be a really helpful tool in that way. The problem with abstinence is that if you slip, you say, screw it, right? You say, well, I messed up, and then you're more likely to do it all the time and not get back on the wagon. On the other end of the spectrum, we have the harm reduction model, right? And the idea here is, well, if the behavior is going to happen, try to do it in a safer way, right? Big examples of these are things like needle exchange programs to cut down on the risk of HIV transmission, hepatitis C transmission, safe injection sites where there's people nearby with naloxone in case anyone overdoses. But smaller scale versions of this that I tend to see in my treatment might be things like, someone's drinking 5 days a week and they say, okay, I'm just going to drink on weekends. So they're not cutting out the drinking, they're just doing it less. Or I've seen people do this with self-harm methods where they'll say, okay, this method is landing me in the hospital a lot. I'm going to do this method instead. The pros of harm reduction are that you're going to feel a lot less shame and guilt if you do have a slip because you're not aiming for no behavior. But the cons is that you never really stop the behavior, right? And it's really easy to return to the prior frequency. Those people that I work with that say, I'm only going to drink on weekends, typically go back to weekday drinking or smoking weed or doing substances, right? So what if we take these two approaches and combine them? We get this very cool thing called dialectical abstinence, which is on the abstinence side, you are making a 100% commitment to abstinence where it's like, this is a problem for me. I cannot do this anymore. This is messing up my life. I need to stop. Like it just cannot be an option. Remember that closing the garage door and keeping it shut kind of thing? No room under the door for the elephant to come in. I need to stop, right? It's more of an internal recognition. It's kind of similar to step one in AA and NA, like recognizing that you're powerless over your substance. It's like, I just got to stop. 100% commitment to abstinence. But on the harm reduction side, what do I do if I have a slip, right? You're planning for relapse as well. So it's not totally making it in your mind this all or nothing thing where it cannot happen. It's like, I know the power of substances. They're very compelling. And if I slip, here's what I'm going to do. Having a plan. I'm going to tell my therapist. I'm going to go to a meeting. I'm going to tell my sponsor. I'm going to let my parents know, right? It's building in a plan for relapse. The reason I'm covering this skill today is because I think it's really important for family members to keep in mind too. I think that the version of this for families is you hope in your mind on the abstinence end that your family member never does the behavior again. You maintain some hope. And if there's a slip, try to avoid jumping to everything is ruined. This is terrible, right? As I said in the previous slide, relapse can be part of the process. So your own version of harm reduction might look something like, this doesn't mean that she's going back to the same frequency. This doesn't mean all hope is lost. This is my plan for if she slips. If she slips, here's what I'm going to do. I'm going to talk to my therapist. I'm going to be planful with how I respond to this, right? All of this can be helpful for parents as well. Right? So it's like, how do you step back and not totally jump in and catastrophize? But does that just mean you watch your family member, your child, whoever, right? Does that mean you just sit back and watch them crash and burn, right? No, right? And I want to spend our remaining minutes. There are resources for family members that can be really effective when you love someone that is struggling with these problems, right? On one end, there's things like Al-Anon and Alateen for teenagers that can really help with that over control emotional reactivity, how to take a step back. And on the other end, there are things you can do. You don't have to just sit there and watch your family member self-destruct either. You can set boundaries, you can set contingencies as well. So let's talk about these options. The main focus in Al-Anon, if I were to summarize it, is this idea of detaching with love. And I'm just briefly going to read what it says on the left side of my slide. Detaching doesn't mean not caring. It's taking care of yourself first and letting others take responsibility for their actions without trying to save or punish them, okay? So detaching with love, I actually asked a family member who's in Al-Anon, how would he describe what detaching with love means? And he gave me an example from the daily readings of Al-Anon that I really liked, that I want to share with you. And the example is that there was a woman who came to Al-Anon whose husband would pass out drunk every night, fall out of bed, and she would hurt herself every night pulling him back into bed. So she'd be throwing her back out, struggling, lifting him. And every morning she was waking up with a terrible back. And she gets to Al-Anon and she learns about detaching with love, right? And she goes home and maybe her first pass isn't so great. So she gets home and she's like, okay. And her husband does it that night. He falls out of bed and she sits there and she's staring at him and she's like, yeah, you're going to wake up in the morning and you're going to have painful back. I'm not going to hurt myself. Good luck. And she's like mad, right? And the woman goes to Al-Anon the next day and says, I did a great job detaching with love. And everyone in Al-Anon says, it just sounds like you were angry and like spiteful and hoping he suffered. That doesn't sound like detaching with love. And she goes, oh, right. Okay. Let me try that again. So that night she goes home and he falls out of bed again. She doesn't break her back trying to pick him up and get him into bed. But she also doesn't just spitefully look at him and with revenge in her heart think you're going to be the one in pain tomorrow, not me. What she chooses to do instead this evening is she gets a blanket and with love puts it on him, right? She is not fixing the problem for him. He will have the exact same consequence as he would have in the spiteful condition, right? He is going to wake up in the morning and suffer his own consequences. He is going to wake up with a sore back and neck and feel really bad. But she is having a much different internal process around the whole event, right? This time there's love in her heart. I still love my husband. He has an illness. I will put a blanket on him as a gesture of love, and she'll feel a lot less angry and a lot less spiteful, right? And I think Al-Anon, for those interested, is a very helpful group, again, for helping with that over control emotional reactivity. Like, how do I detach with love? How do I still love this person despite all of these problems and despite all of this fear, right? So I really, really strongly encourage Al-Anon or Alateen if you're a teenager. There are groups in person and online all over the world, so you can look. I always encourage people, if you don't like the first group you try 2 more, right? Every single group is different, so try to find your people. If you want to learn a little more about detaching with love, Hazelden offers a handbook on detaching with love. It's $5. It's on the Hazelden store, so if you Google Hazelden detaching with love, you will find it there. Okay. So while Al-Anon focuses a lot on managing your internal reactivity and responses, there are programs that help a little bit more on the how do you respond behaviorally to addiction issues in your family, right? So there's a program called Community Reinforcement and Family Training that I am not personally trained in, so I'm not going to spend a ton of time talking about it because I don't want to do it any injustice, but I've heard really good things about it because it sounds like it helps with the taking a step back piece, like the detaching with love, and gives strategies for actually managing behaviors. Like, how do you respond if an event happens? So how do you set forth positive reinforcement? How do you set forth contingency management, et cetera? And there are also free trainings online and in person. If you're not able to find one in person in your area, I saw a lot online in Colorado. So if anyone's interested in getting trained in this, by all means, check it out. It sounds like it has a little bit more support on the behavior piece. So while I'm not trained in craft, I do a lot of work with families on how do you manage contingencies, meaning like, how do you set forth consequences, basically, summarize it, and set limits and boundaries around people's behaviors. So like I said, you don't just sit there and watch your kid crash and burn. You don't just sit there and fully enable the behavior, right, until things blow up. You have to set boundaries, especially, this is so important. If you're a parent of teens or young adults, it's literally your job. I mean, if you don't set any boundaries with a teenager, you could actually get into trouble, right? If you just endlessly let them engage in certain behaviors. So what are contingencies? Contingencies are a way of managing your own responses to a behavior, right? I cannot say this enough times, you cannot control another person's behavior, but you can control your own responses to it. So for example, like I've had patients say, I set a boundary with someone. I told them they weren't allowed to talk about XYZ in front of me. And I often say, that's not a boundary. A boundary is saying it's not, you're not allowed to talk about it. The boundary is, I will not listen to that. I am leaving, right? You can only control your own behavior. You cannot control other people's behaviors. So an example of a boundary might be something like you're noticing your kid is spending all of their allowance money on substances. Instead of saying, you're not allowed to spend your money on that, it might be, I'm not giving you any more money, kiddo. Like, I can't enable this, right? That's a boundary. Contingencies are most effective when they are planful and non-reactive, right? So what I would not recommend, let's say you notice your kid spent money on Venmo and that's their usual method of buying drugs. I would not recommend kicking their door in the morning and saying, you're doing it again. I'm done. I'm not giving you any more money. You know, and if you do it again, I'm going to take your laptop away, right? Making threats, being loud and reactive. The only thing that does, as I mentioned earlier, is your kid just gets more sneaky. Like they actually just get better at hiding stuff. Contingencies are much better. You can set the exact same boundary in a nice conversation, right? So you let your kid know like, hey, there's something we need to talk about tonight. You sit them down. You want to be very behaviorally specific, right? I'll tell you what that means in a second. And you say, you know, sit them down and say, listen, like, I really love you. You might be mad at me about this. I'm so worried about you and I love you so much that I can't give you money anymore because I'm certain that it's being spent on drugs and I'm sure it's being spent on other things, but this is what I'm going to have to do, right? And you say something like, if I see a Venmo charge, I'm going to have to then limit your account access or whatever, right? It's saying it with a lot of love and very planfully. It's best if the person can actually get on board. So I've had people who actually ask their parents for things like drug testing because they want to be sober, right? It doesn't work if you're the one saying, I'm going to drug test you. And if you fail the drug test, then I'm going to take, right? You really want to be very planful and loving with the way you set these contingencies. When I write that you should be as behaviorally specific as possible, for example, if you have someone in your family, for example, that is missing their SAT prep class every Saturday morning, and you say, I will not give you a ride if you miss your class because you were drinking the night before and you're too hungover, that's the contingency you set. And if this happens again, like I will give you access to the car, for example. If then the kid goes out and drinks a different night and doesn't miss their SAT class and you punish them for that, they're going to say, you just said I had to get to my SAT class on Saturday morning, right? You want to really label what behavior you're hoping to change, right? So again, if you want to check out the craft group, it can help a lot more with how you do this, but it's very important to know that boundaries are okay, right? If you don't want to give your family member a ride to the dispensary or the bar, you don't have to give them a ride, right? If you are worried, and they might say, you're wrong, I'm not going, you're allowed to set boundaries and that's okay. I could probably do a whole talk on how to do this, but for now, I just want you to know this is an okay limit to set. It's reasonable. You set the boundaries with your own behavior, not controlling their behavior. And with that, just summarize what we talked about. There's a lot of overlap between BPD and substance use disorder. When you're a family member that loves someone with both of these challenges, you face a unique set of difficulties because your baseline worry is typically a lot higher. And there are a lot of tools that you can use to support yourself and your loved ones through this process. And with that, I just want to say again, thank you so much for having me. It is such an honor to give this talk. Thank you.